Welcome to Hashtag with Navguzi Chwanuka. This is a place where we help you unravel social constructs, discuss self-development in line with mental health, emotional well-being, and everything in between that directly or indirectly affects us in the millennial world around us. If you're hearing my voice for the first time and are the kind of person who is not scared of being a better version of yourself even if it requires you to contradict who you were 24 hours ago, consider this your virtual home. I'm your host, Navguzi Chwanuka, and I cannot wait to engage with you in the various conversations. Today, I'm joined by Dr. Denis Agaba to talk about one of the most commonly thrown around words in the realm of well-being. Now, I don't know what you know about OCD, but to many people, they associate it with being merely a neat freak or a perfectionist. And based on the polls I ran on social media, many said it is not a mental health disorder. It is for this reason that I ask you to share this episode with as many people as you can, because in sharing it, you may help one of your loved ones in feeling seen or heard. I had this conversation with Dr. Agaba over a month ago, but I can assure you that this episode is as timeless as many of the conversations on this podcast. Let's dive into it. Dr. Agaba, welcome to Hashtag with Navguzi Chwanuka.
Pleasure to be here.
So for people that have no single awareness of who you are, please introduce yourself and we jump into the conversation.
Great. So I am Denis Agaba. I am a psychiatrist.
Right.
So I am a medical doctor with specialized training in mental health, and that's what makes me a psychiatrist.
Mm-hmm. There has to be more.
There's definitely a lot.
Because you can't just define yourself to. That's very enclosed.
Precisely. There's
more of you.
I'm trying to find out where to begin.
Where to begin? There's too much.
Well, what else can I say? I am happily married to one wife, a woman.
You're sick.
We have to clarify these things in the day and age that we live.
Oh, that part. Sorry. Yeah.
Can't be too sure, right?
Yeah.
Yes, I am part of the Rotary fraternity. I part of the Rotary Club of Kampala, the core.
Mm-hmm.
So I love to serve.
Yeah.
I am a Catholic.
I landed on you in church.
Yes, not once actually.
Yeah, but the first time. So I don't remember. Was I drugged that day? And then I went in to give offertory and I was like, oh my God.
Really?
I've been looking for this guy. And I went back and told my cousin, there is this person I've been looking for. He's in church.
You'll be sure to find me there. Yeah. And etc.
Yeah, etc.
The more will come as we discuss.
Yeah. Rotary, is it Rotary or Rotaract? It plays in my mind.
Why?
I don't know. I'll find out what it is about. It's very ambiguous for me, I think. Or maybe I haven't. I haven't given it time to understand.
Yeah.
But it feels like, hey, those bourgeois people out there.
That was Interact in school, right? Like here, it's not that anymore.
It is an extension of the adults version. So you've mentioned the part of being a psychiatrist, and you are the very first one on the podcast.
It's a privilege.
It is, to honestly.
Surely not the last. I know many more will come.
But I'm also manifesting that you return.
Lovely.
Because there's a lot more for us to talk about.
I'd love to. Yeah.
Mostly people have been hearing from psychologists.
True.
I don't know how many I've had. I'm trying to run through my mind, maybe 4.
Yeah.
But not a single psychiatrist has been on board. So differentiate for us a little bit between a psychiatrist and a psychologist.
Okay. The psychiatrist, I'll just say that we work together.
Uh-huh.
Whenever you hear the word psych is Latin for the mind.
Mm-hmm.
Okay, so anything psych, that's the mind. Okay,
yeah.
So a psychologist. Okay, so like I mentioned, I teach, right? So
yeah, you did.
If you hear ology, that is study of, right?
Okay.
Biology, the study of life, and things of that kind. Yeah.
Mm-hmm.
So psychology is the study of the mind.
Yeah.
So people who have studied the mind generally will be psychologists. Okay. Now, psychiatry, on the other hand, looks at the medical discipline, okay, that looks at the study of the functionality of the mind, how the mind works. In this case, that's what we call the physiology of the mind, the illnesses of the mind, how to treat them, and how to prevent them. Okay, so for someone to be a psychiatrist, to be part of this discipline, they first and foremost must be a medical doctor. Okay, so you do your 5 years at med school, so you're a medical doctor.
You fasted the 5 years?
Oh, yes.
Hey, and then?
Then you specialize. So you choose it. So after you do your 5 years and your internship, you're a general doctor. Okay, so you understand the way the entire body works and how to identify disease and treat it. So for you to become a psychiatrist, then you specialize. So the body is quite huge and very wide. So you choose. The same way, if I am a cardiologist, I are focused on the heart.
Yeah.
If I am a nephrologist, the kidneys. Okay?
I had never heard of that.
Oh. Well, the mind is an organ like any other. Okay?
Right.
So for the people that specialize, that now narrow down from the rest of the body to just the mind, those are the people that we call psychiatrists. So they are medical doctors who have specialized in understanding how the mind works, the diseases of the mind, how to treat them, and how to prevent. Okay, so that's what psychiatry is all about. So it's a medical discipline.
Yeah.
Okay, we come from the element of function, disease, treatment. Okay, so a psychiatrist really understands a lot more than just the basic functioning of the mind, but on a much deeper level.
Yeah.
On as to how the mind is formed, how the mind works, why does it do this and not do that, then how does it become distorted, what we call pathology, how does it become ill, and if it's ill, how do we get it back to where it should be. So we have, as part of the team, what we call the mental health care team that we work with, we have people who are called now the clinical psychologists or psychotherapists. These people have studied the basic general understanding of the mind, okay, psychology, right, which all of us do at some point in time. Almost people get like, there's a course in community psychology and things like that, just generally understanding how the mind works and things about that. So if you do clinical psychology, then you're learning how to apply this knowledge that we generally have about the mind in the treatment of mental illnesses. So they specialize in what we call psychotherapy. So psychotherapy is one of the ways in which we treat illnesses. I'll get into that a lot because our topic today has a lot to do with what we call psychotherapy.
Yeah.
So the psychotherapists, people who have done clinical psychology, they are able to use some of these skills to treat these conditions. Okay, so they are part of the team, but because again you can't do everything, we have people that support us by they're trained to administer a particular type of treatment, which in this case is psychotherapy. That's what the psychologists, clinical psychologists, ideally do. Okay.
I found it necessary for us to also put a disclaimer. When we talk about the psych part, we're not involving psychics.
Oh, okay. Yes.
There's a difference.
I hope it... Yeah, there's a big difference. There's a big difference.
Yeah. So today, what I really wanted us to talk about, first of all, thank you for elaborating or helping us understand that part. So what we want to understand more and what we are misusing a lot is OCD.
OCD. Yep.
Yeah.
Everyone every other day will just come and say, oh, you see.
Everyone.
It's the easy excuse. It's my OCD.
Like, dude, shut up. And personally, I've been, I usually say accused of having it.
Yeah.
Like, if you these are people in different places, and they're like, "Oh, you're OCD." Oh, and then you start double guessing, like, am I? Maybe.
No.
What? Huh? Yeah, you know? So let us get into the conversation with true or false. OCD is only about being overly tidy or organized. True or false?
Very false.
What is OCD then?
OCD. It's an acronym to start with. Right? So, Obsessive-Compulsive Disorder.
Right.
Key emphasis on that term, disorder. For something to be a disorder, it means it's out of the norm, right? And typically what we like to say, for us to define something as a disorder, is it leads or it impairs your social and occupational functioning. For something to be a disorder, it means you're not able to function. Right. You have this particular thing. You can't come to work. You can't be around people. You can't socialize. You can't get stuff done. You know, if you had OCD, the fact that this is a disorder is you wouldn't be able to live your life the way you would want to or you're meant to. So first and foremost, this is a disorder.
Yeah. And
we shall see how that comes up as we go into the depths of that. And this disorder is comprised of two things, obsessions and compulsions. Okay? So for us to understand OCD, we need to understand what obsessions are and what compulsions are. Now, before I get into OCD and how OCD comes to be classified as a mental disorder, I would want to first begin by giving us a background of what the mind is.
Tell us. I'm telling you, you're the first psychiatrist.
Can you differentiate between the brain and the mind?
No, the brain is the organ. The mind are your thoughts. Rough idea. And very much on the right track. Okay, so I like to think of it. The limbic system, is that where you get into that?
I can see you've done your homework. So think about it this way, okay? So the brain is the hardware and the mind, the software. Okay? I hope that makes it a bit clearer.
It is.
Right? So they are quite intertwined, but they're not necessarily the same. Okay? Actually, the doctors that deal with the brain are neurologists or the neurosurgeons. Okay?
Right.
And we who deal with the mind are psychiatrists. You can see we're quite different.
Makes sense.
Very different specialties. Okay?
So
there's guys who do hardware,
Yeah.
And for us, we handle the software, right? The same way I have a Samsung, which is hardware that runs on Android, which is software.
I think one person will handle everything.
Not necessarily. Not necessarily, right? It's not the same, right?
Okay.
And so the mind now, the software I'm talking about, is responsible for three main things, okay? Mm-hmm. How you think, what we call thoughts or cognitions, how you feel, in this case, your emotions, and how you behave, now your actions, okay? So thoughts, feelings, and behavior, right? Or cognition, emotion, and action. That's what your mind is responsible for. I think I mentioned in the discussion we had the other time that you see, if you've been dumped, technically speaking, your mind broken, not heart. The heart just pumps blood, right? Your feelings are in your mind.
But we feel it here. The caffeine can be here in the chest.
Okay, technically speaking, it's in your mind, okay?
Yeah.
So, with that background, so a mental disorder is one that leads to a distortion of your thoughts, distortion of your feelings, distortion of your behavior, okay? For someone to be having a psychiatric illness or a mental illness, it means either they're not thinking right, or their emotions are not in order, or their behavior is out of check. Okay, so with that background, let's get back into obsessions and compulsions. So obsessions are a disorder of thought. Compulsions are a disorder of action. So obsessions, by definition, are intrusive, unwanted ideas, images, fears, thoughts, or worries that are experienced as uncomfortable, unpleasant, distressing or anxiety-provoking thoughts. So I get these ideas in my mind, okay?
Yeah.
There are these thoughts that come up. Could be worries, could be fears. One, they are intrusive, meaning they come. I am not in control of them.
You could be
I
just
don't want
minding
them.
You could be just minding your business, and
Exactly.
then it shows up.
I'll give you some examples, okay? So I don't want them. It's not me that's thinking about it. No, they come. They're intrusive. They are unwanted. They are distressing, okay? So I don't want to be thinking this way. But for some reason, it's like something keeps making me think a certain kind of way. It almost feels like an external force, okay, in this particular sense. And they are very, very uncomfortable. They are very, very distressing, okay? And then compulsions are usually behaviors. They are actions, repetitive behaviors or actions that are performed usually to ignore, reduce, or eliminate the anxiety that is caused by these obsessive thoughts. So I'll give you a typical example of a client that I once had who had OCD. Now typical day, right? He would leave the house and 30 seconds after he's walked out, he gets a thought. Did you close the door? Okay? So he stops. Did I close the door? Okay. Maybe not. Then he'll go back, right? And he'll check.
Yeah.
It's locked. Okay, cool. Then he'll walk out. 45 seconds later, the thought comes back. Did you close the door? Are you sure? Like, did I close? He'll go back.
Yeah.
And again, he'll check. Then this time he'll get the key, he'll open, shut the door again, lock. Okay. And he'll walk away. A minute later, the thought comes back. But are you sure you closed the door? And then he'll go back.
Are you serious?
He'll spend an hour going back and forth from the door. Because did he close the door? Now,
Is it?
the obsession, the thought.
Yeah.
Did you close the door? Are you sure you closed the door? What's the compulsion? That he keeps coming back. He keeps coming to check. He keeps coming. So it's a disorder because, again, now you can imagine if he had an appointment.
Oh, my God.
Is he going to show up? Does he want to keep thinking whether or not the door is closed?
It's just
Is he
coming up.
enjoying all this?
You cannot. You can't enjoy it.
He's distressed. He's uncomfortable. And then, of course, he's going to keep getting anxious. He's not going to function.
Yeah.
That's an example of OCD.
It makes sense. I would like for us, I think, to have a slight distinction because now there is a moment where I was really burnout. That was in April. And I was just routine. What is the word? What's the usual word they use for routine? I've forgotten it. But it was just routine. And I wasn't really paying attention. I'm trying to look for that specific word. And it got to a point that I wasn't attentive to what I was doing. That it's just you wake up, dress up, leave. You're not even mindful.
So an automatic kind of thing.
Autopiloting.
Autopilot, yeah.
Yes. I was autopiloting for the first 3 months of the year.
Yeah.
And it ate me up in April. So I realized that I was just doing things, not even putting my mind there. And then I realized that when I would lock the office, if I'm the last one there, and I lock mid-journey, I'm like, oh my God, did I lock the padlocks? And I have no single recollection of even touching the padlocks. And I would just go home praying. I was like, God help me. I hope I really locked. And then you walk in the morning tiptoeing, you're like, did they find it open? They didn't. Okay. So I feel like people need to also have an awareness of the distinction of that.
Yes, definitely. Now, you got a thought, right? And we have many of these thoughts. Premonitions, I think is the word. Right? If it was OCD, one, you would not have gone home. You would not have slept that night. One, because again, it's intrusive.
Yeah.
And it doesn't let go. So it's not a simple suggestion. But you didn't. And then a lot more will come about that. And so most likely, you would drive back. If you had OCD, like you would not be comfortable. You would be on edge. It would be, your heart would start racing. You're uncomfortable. You'll get sweaty. So these are the anxiety provoking. So again, anxiety is a whole other thing, which we can talk about. But you begin to get all these physical symptoms. You're churning in your stomach. You're having difficulty breathing. You can barely concentrate on anything else because the thought is, did you look? What you went through is something very different altogether.
Exactly. That's why I wanted us to
which
distinguish
is not OCD in a sense. And these are not really obsessions in that. It's, you are, the typical word is distracted. Right? So your mind was...
I wasn't present.
Nowhere.
Yeah.
And everywhere at the same time, right? So so that can happen, definitely, that we are quite mindless. We're just going through things in autopilot, like you mentioned. So we're not very conscious about what we're doing, and that can happen. More so if you have burnout or something of the similar. And that would be a whole other podcast for us to get into.
Exactly.
So I'm going to try and avoid addressing that. But with obsessions, again, like I said, very intrusive, very unwanted, and they are going to cause a lot of distress. And with obsessions then come compulsions, because the compulsion is done to try and relieve the anxiety, okay? But it's never quite successful. And that's why you find that they have to keep doing it over and over and over again, okay?
Yeah.
So the most typical one that tends to happen, another common form of OCD is when we have cleanliness, right? So the fear of disease. And I saw quite a number of people during the COVID pandemic who, one or two people who came down with OCD. And this particular client that I saw had got COVID. So got COVID, was diagnosed positive, eventually, was able to fight off the virus. But when she came back, she could barely function, right? Because she was seeing COVID everywhere, right? So she'd have her own sanitizer, she'd sanitize all the time. She would not shake hands with anybody. She would not sit on a chair sat on by someone else. She would not choose, even if it's been cleaned, even because she was working in the hospital, and would sanitize the whole place. But no, it wasn't enough, So she had one particular chair, and she stopped everyone else from using that chair. It was only her who could use the chair. But even that chair, she was always spraying it, And then if she ever stood up, before she could sit again, she had to spray it. So these were compulsions to try and deal with the obsession, the thought that there just might be COVID there. There just might be COVID there, right? And so she couldn't work. She would stay stuck in one place because there just may be COVID pretty much everywhere. In her own house, her children, it was quite interesting. If you went to the market, at the door, you'd leave your clothes. There's a basket where you'd leave your clothes. You had to be sprayed.
Wow.
She would cook her own food because she just kept seeing COVID everywhere. So she had these thoughts, she kept getting these intrusive thoughts that, wait. So even her own kids, she had to pretty much cut herself away from them. And she was very, very uncomfortable, very, very distressed. Even her own bed, she'd have to spray it before she goes to sleep. It was very difficult. Yeah, but eventually she came and we were able to give her the care that she needed. So again, it's excessive. Okay? And like I mentioned, it causes social and occupational dysfunction. I'm not able to work. I can't live with people. Okay? That's OCD.
It makes sense. But hey, man, for the kids, the home.
It's not something pretty.
Exactly.
It's not something fashionable. It's not something that I can just laugh about. And I have OCD and I'm going by my day and I'm living life normally, but I have some OCD. No, you don't have OCD. So I think it's important that we...
my OCD. You guys. Yeah. The way how they usually say it. Now, when you mention the part of your patients and the experiences that they had, and it comes to also to your area of expertise as a doctor, as a psychiatrist, does it mean that this has to be diagnosed?
Yes.
How is it diagnosed?
And now, just to go back one step. Okay? There has been a disorder,
right?
A dysfunction in the mind. So my thoughts are not the way they should be. My actions are not the way they should be. There's a change from the norm. Okay, so there's a very drastic change from the norm, and so there is disease. Now it has to be diagnosed so that it can be treated. And so, how is it diagnosed? Well, we have what we call the psychiatric interview. Okay, so where I ask you questions. Like I mentioned, it's a software thing. So even many of our investigations are more software. So in conversations and when you describe what's happening, as I ask various questions, I'm able to tell that, okay, yes, this is an obsession, this is a compulsion. This person probably has OCD. So there's what we call the psychiatric interview. Then we have particular tests that we do, standardized tests, that help us to be able to diagnose. Okay, so they have particular parameters, and we ask particular questions, and it's like a checklist which you tick off, and then we have particular tests. There are quite a number that have been made, some that have been validated even here. So many of these, again, were made for people on the other side of the world. But we also have, I think, one which can work here. What would call the SCID, which is it's a diagnostic interview that we can use to be able to diagnose these different conditions here.
What do you mean by there are those that are not meant for us?
They were designed because again, a lot of psychiatry of the mind is very cultural sensitive, because the way we think about things is not universal. There are particular, I could say, beliefs that we have here that are culturally, I would want to use the word universal or acceptable in our society here, which are not acceptable in a different society. So when you're designing these tests, you have to put into consideration, the cultural and societal norms of an area, okay, for you to be able to get it right. I'll give an example. We have what we call cognitive tests, okay? So things like testing what you call the IQ, intelligence and cognitive tests, okay? And so these particular cognitive tests, one of the things that we do is they test your ability to identify particular things, right? So, for example, there are particular animals that don't exist in this part of the world.
Chihuahua. Is that the right pronunciation?
Or maybe a kangaroo.
Panda.
Or a panda, right? So if you show the typical Muganda, the picture of a kangaroo.
Why are you picking on us though? Just say Ugandan.
Ugandan.
Yeah.
There are also differences depending on the region and things.
That's right.
If you showed them a panda and you asked them to name it and they didn't get it right, you wouldn't be right to conclude that they are not cognitively sound.
Yeah.
Okay? Because you're exposing them to something that is not within their society and not within their realm of knowledge. Okay? So many of these tests are similar in that sense. Yeah? That you need to be able to ask questions and need to understand the context.
Right.
Where this comes from. Because then you might misdiagnose someone if you don't get that right. So many of these tests, because like I said, it's really software, it's thoughts, it's perceptions, beliefs. And so many of these, because a lot more work has been done in psychiatry away from here, it's still a very infant field. It's something that's just beginning to pick up and to grow. So we need to also design tests that would work best in our environment here. So we don't have very many of those that have been validated to also be effective here. Yeah.
Oh, yeah. Wow.
I think the SCID is the one that has been so far worked on.
So you mentioned the last patient that you talked about after suffering with the COVID, and I did not have a single awareness that someone can actually just find themselves getting the disorder. For some reason, I imagined that it's part and parcel of the person when they're giving birth to them. So what are the common triggers or causes that may contribute to the development of OCD?
So when we talk trigger, when we talk cause, that's a very broad concept when it comes to mental illnesses. There's no one cause. It's not like how you see malaria is because of plasmodium, right?
Why are you saying that word? It is what is the mosquito? Just say the mosquito.
Anopheles mosquito.
Yes, why are you saying the other words?
It's not the cause. Okay, so There is something else.
Okay.
So at least in that, it's very clear that, if a mosquito bites you and it has this particular parasite called Plasmodium, you will get malaria. Mm-hmm. Straightforward.
Yeah.
With psychiatric illnesses, it's a combination of what we like to call the biopsychosocial, model. So there are biological factors at play, there are psychological factors at play, and there are also social factors at play. Biologically, we are speaking things like genetics,
Yeah.
So with the studies that have been done, some people are genetically predisposed to conditions of this particular kind. Mm-hmm. So you might find that, this is something that runs in families. Okay, so maybe your paternal aunt had OCD.
Yeah.
Because of the genetic predisposition, so it's coded in my DNA, this possibility of developing OCD. So there's a genetic predisposition that has been described. Then on top of that, in the biological, like I mentioned, the hardware and software are not independent of each other. But we've seen that in the brain itself, there are particular chemicals, there are particular regions of the brain that are responsible for different things. And we've seen that for people who have OCD, there are some derangements in the chemicals in the brain, in the structure,
Even the structure?
Even the structure.
Whoa. Okay.
Again, like I said, this is not something that I can just live with happily. No, there's an actual distortion in the functioning of both your brain and your mind.
Yeah.
And that's the rationale we shall get to for medication. That's why we'll give you particular medication. And when you take this medication, you definitely improve, right? Because again, the mind and the brain are very closely intertwined. So if there are distortions in the mind, in the brain chemistry, it's also going to affect the functioning of the brain itself. So there are particular areas of the brain. You mentioned the limbic system and things like that, which is very good. There are some other areas of the brain that we've noticed that when there is some form of distortion in that part of the brain, we get thought abnormalities. When something happens in this part of the brain, we'll get obsessions, we'll get compulsions, So that's part of the biological understanding of this condition. The other is now what we call psychological. This will then go into thought patterns, the way I perceive things, the way I think about things. It goes back to my previous experiences. So traumas, past, what we call negative life events. So for example, for this particular client, getting COVID was a trigger for her OCD. Interestingly, this particular client as well, her mother had OCD. Much as it was not diagnosed.
So could it be looked at as it's gonna sound wrong because I'm speaking to a doctor, but I'm going to bring it in the way how I understand sickle cell disease.
Yes.
That there are carriers and the sicklers. So in this case, but that's different. That is really different.
No, you're on the right track. Go ahead.
Because a sickler can't be triggered into getting sick. You understand that? But that's how I wanted to bring it out. That it was silent, and then something exacerbated it, and the science started showing.
So you're actually very right. Even for sicklers, they have moments when they are perfectly fine. Okay, and then of course they do get triggers. Then they get into crisis.
Yeah.
So it's something similar to that particular kind. The way we like to say or to phrase it is, you see, your genes load the gun, and then the society and your personality pulls the trigger. So you're predisposed. You could get it, but that doesn't mean that you will. Okay, so for example, this lady has siblings. None of them has OCD, but all of them are predisposed.
Yeah.
Okay, think of hypertension, right? You're predisposed if your parent or your close uncle has hypertension. Okay, but if you live a healthy life, exercise, healthy diet, you will not get hypertension.
I'm trying to go to, I don't know how true the story is. I didn't follow it up. But we were at work and these guys were talking about cancer. And they mentioned that Angelina Jolie, I don't have proof to the story. I didn't follow it up. They say that Angelina Jolie found out that in her lineage, there is cancer. And then she just decided to cut off her boobs.
Yeah.
Is that the story?
It is true.
Do you know the story? Oh, okay.
So it's true. So again, even her, there's a gene called the BRCA gene that has been shown to to link breast cancer. Okay, so if someone has the BRCA gene, the probability that they will get breast cancer is almost 50 times that of someone who doesn't have that gene. So you could be radical like her to say, I don't want to take the risk. Let me just cut them off.
Yeah.
Okay?
That's crazy.
But again, not everyone with the BRCA gene gets it. So again, like I said, this is a very not straightforward discussion.
It's not an obvious 1 plus 1.
It's not 1 plus 1 equals 2. Because not everyone who is genetically predisposed will get the condition. So you need like the right set of circumstances in this particular person for us to get this particular condition. So I mentioned you have the genetic predisposition, you have negative life events, you have this particular person's way of thinking and perceiving and looking at life. And all these things together could give us OCD. So usually it will come secondary to traumatic event or what we call the significant events. For this person, it was COVID. It could be I was robbed. Okay, and then I begin to develop these different patterns of thought, of maybe. So it's not one particular underlying cause that this is why you got. Yeah.
And it's now because you're talking about the traumatic events and the negative experiences. I'm wondering, oh my God, then how it all falls back to you to distinguish between PTSD and OCD. It falls back to your...
Precisely. So again, PTSD is a whole other...
Exactly.
Is a whole other disorder, which, again, it would be nice to have a whole other set.
Yes.
But PTSD is a whole other disorder. Related to OCD in a way, but very different from OCD.
Yeah, it's related?
Yes, because some features are similar. Okay.
Exactly. That's why I'm saying the line is blurry.
It's not blurry.
Is it?
If you're seeing it from your side, it may be, but from our side, it's clear.
Yeah, exactly. That's why I was like, it just falls back to your expertise.
Precisely, yeah. So that's why, like I said, it's important for you to get
diagnosed.
A diagnosis from a trained psychiatrist.
Right.
Who will be able to tell that, okay, wait, this is not OCD, this is actually PTSD or some other condition. Because, again, many people tend to think mental illness is one thing. Yeah. The majority of people will say, you work in Mutabika. Aren't they going to throw stones at you? I mean...
Yeah.
Okay? They understand it in one. They think that mental illness is one thing. And I had this particular challenge. I was invited to speak with some people and they wanted me to talk about mental illness. Right? And they're like, we have 30 minutes to talk about mental illness. And I was like...
30 minutes?
Guys... Okay, I spent 30 minutes.
Like the definition.
Exactly. I just spent it defining, right, and breaking down. So we have a whole compendium. So we have what we call the Diagnostic Statistical Manual of Mental Illnesses. We call the DSM, which is like our dictionary of mental illnesses, and it's like this big. So you have a very wide variety of conditions that we call mental health conditions. They all have similarities, definitely, because they all affect the mind, but they are very distinctively different. And so when you come for a diagnosis, we're able to tell what is this thing, and even the treatments will vary in that particular sense. So yes, OCD is very different from PTSD.
Yeah.
PTSD is post-traumatic stress disorder. So similar, but different. I don't want to get into that.
I did have a conversation with a psychologist.
Yeah.
I'm now used to the psychiatrist. You talked about giving medication to your colleague who got better. I had no idea that there was a possibility. I just thought someone just learns to live with it and go ahead with life. They figure out how to, manage. So what are the available treatments that come with OCD? Good.
Now, like I mentioned that, it's biopsychosocial, right? So there are biological derangements. So for us to correct the biological derangements, we need medication. That's where medication comes in, right? If we have a chemical imbalance, we're not going to talk the chemical imbalance away. We need to give you medication. If there's a distortion in your mind, we're not going to just wish it away.
Yeah.
So you need medication for that, for the biological derangements. Not everyone will get medication, okay? But some people will need medication. For example, if someone, as a result of the OCD, gets very anxious, has difficulty breathing, can't sleep at night, so the medication will be to deal with these, call it complications that are coming as a result, okay? if they're not able to function, can't concentrate at work. So we'll give you medication to help you concentrate, to get you going. And the type of medication we give are what we call selective serotonin reuptake inhibitors.
Okay.
Forgive me.
But you are forgiven.
Okay. So these chemicals, these drugs are used to address the chemicals in the brain that do that. Others are anti-anxiety meds because, like I mentioned, the obsessions and compulsions provoke a lot of anxiety. So we give you medications to reduce that anxiety. That's the role of the medications. They don't treat, per se. The medications are here to reduce the symptoms, to reduce that discomfort that comes with the condition. Away from the medications, we do what we call psychotherapy. Now, psychotherapy addresses the thoughts. So the origin of this problem is in your mind, is the way you're thinking, because your thoughts have been distorted and deranged. Psychotherapy is aimed at changing, treating, correcting the way you're thinking. Okay? The typical form of therapy we use is called CBT, cognitive behavioral therapy, for OCD. So it's very different from that of depression, very different from that of PTSD. So there's there's CBT for OCD, cognitive behavioral therapy for obsessive-compulsive disorder. And that is typically getting into your mind, identifying the distortion of thought and correcting it, changing it. Okay? So that's what psychotherapy is about. In the movies, you just see this guy sitting down on the couch,
you lay
right?
on the
and just tell me what happened, just talking about things. But it's not just jazz. We're not just having a conversation. No, we're treating. It's therapy. It's a treatment. There's a disorder and we are fixing it.
It looks very bougie in the movies.
It's not bougie as such.
In the movies,
it's treatment.
Let me tell you, in the movies, it feels like not all movies. It also matters what kinds of movies that you have landed on, because I've had to, I'll talk about it later. I'll not say the name of the series. But people have this idea, you see, because even for the images that you see someone lounging, and relaxed, and you're like, these guys are just wasting money.
No, they're not. It's a lot of work. It's a lot of work, right? Like it's taken me 3 years to learn how to do that kind of thing.
Yeah.
Right? Okay, 8 years technically.
8 months.
If you think about it. But yes, so it's not just, it's actual, there's a lot of work that goes into it. It's actual for us to be able to get the therapy done. So that's the second thing that we do, psychotherapy. So we give medication, we do psychotherapy. And the third is more in changing the environment. Okay? Because oftentimes the environment in which you are will contribute to the way you think about things. Okay? So there are other measures in place that we put in to try and, resolve the conflict that you have in your society. So it may be the people that you meet with, it may be family support, it may be, some form of occupational therapy that also helps to deal with many of these compulsions and the like. Yeah. So for example, could be reminders or other different checks that we would have to create, checks and balances in your environment to just help you counteract many of these, obsessions and compulsions. So for example, having a friend, with whom you discuss and talk, and if you tell them what you're thinking, they could be able to just help you. Wait, that's an obsession. That's not really true. That's just in your head, and help you to distract you, help you to cope better. So all these are ways in which you treat this condition. So it's a biopsychosocial model of care. We don't only give you medication. It's like we just write you a script and be like, okay, go, you'll be fine. The meds have to go with the psychotherapy, and the environment in which you are needs to be conducive for you to be able to heal.
If someone has to come to you for therapy, do they have like a time? The way how you give antibiotics for 5 days?
Yeah. So the typical duration of treatment is about 6 months.
Hey, that's close to pregnancy, man. It's close.
Well, yeah, because again, these are very difficult things to approach.
Yeah.
Because like we said, there's real distortion. Right? And so there are different processes that we go through in therapy. So ideally you'd meet like once a week for the start, then maybe every fortnight, until we get down with the time that. So there's a whole process that we follow. Okay, so it's very structured. That session 1 we discuss this, session 2 we try this activity. So we don't just swing by.
Yeah.
There's particular things that we have to do along the course of this time. So typically it would take about 6 months. But also that depends on how the person is responding. So there's everyone's journey is different, right? So unlike malaria where
3 days.
3 days and we're done. It will be different when it comes to mental health conditions because our experiences are different.
Right.
And we as individuals are different. So the trauma you've experienced is not the trauma I have experienced. And we have to deal with all those particular things.
Yeah.
So you'll find that it will vary from person to person. Some people may do, but typical time is about 6 months. Some it may stretch, others may be a little bit shorter, but typical time about 6 months, 6 to 9 months is the typical duration for therapy. Yeah.
At least there is hope that someone can come out
hope.
to their end.
There's definitely hope. Well diagnosed with the right treatment, it is curable.
Curable.
Yeah.
Very valid. Are there lifestyle changes or self-help measures that someone can implement to help them with dealing with OCD?
Yes, they are, but it would depend on the particular obsessions and compulsions that the particular person has. So there is no one size fits all when it comes to this particular disorder, right? So they're very particular. So it will depend on what particular obsessions I have, and so the lifestyle measures would depend on the particular types of obsessions and compulsions that I have. So because typically,
if we have to look at the 2 patients that you've talked about, is there something that we can pinpoint, something that they could use to supplement their treatment or something like that, like self-help?
No, it can't be self-help.
No,
because ultimately,
like lifestyle changes, like you're also contributing to your well-being.
Yes. So because the root of this is in the mind, many times these are going to be around how we think about things, what things we pay attention to and what things we don't. So we have particular, let's talk about self-help. Many times when people have obsessions and compulsions, they then become very anxious and distressed. And they can typically get into what we like to call a panic attack. Okay. So one of the self-help measures that we use, for example, if someone is getting into a panic attack and they're worked up and they're feeling very anxious, are things like what we call breathing exercises. Right? So if you do this rhythmic breathing exercises, you're able to, work with the anxiety.
Yeah.
Okay? For example, this particular patient I had who had issues with
the locking of the door.
Locking of the door. One of the things that would happen is, even the 4th time, right? So he's just gone back. He's double-checked. He's confirmed. He's very sure that he's locked. And now when he starts to walk away, of course, the thought will arrive, And he will initially try to ignore the thought. And then he would feel himself feeling very uncomfortable. Then his heart is beginning to race. And so one of the things that we do is, if in the moment you're able to distract yourself, so do the breathing exercises, gradually the anxiety begins to go down.
I feel like that his position is very hard because you risk leaving the door open.
But remember, he's just done it 4 times.
Yeah, but oh my God.
Do you get it? So at this point in time, even he knows the door is locked.
Oh, okay.
You get it?
Yeah.
And that's what you have to understand. It's not rational. It goes against ration. Because, the first time, did I? Okay, you go.
Yeah.
You're locked. You come back the 2nd time. You come back the 3rd time. Like, now you're sure, right?
Yeah.
Beyond all reason. And this is where it gets interesting because the obsession will remain even with all the evidence placed before you. Because, again, your mind is distorted. You will still keep getting that particular thought. So we'd have to teach him how to deal with the anxiety that comes with these particular obsessions, because that's what drives him back. Because if he doesn't go back, he's not going to calm down, if I could use that. So if you find alternative ways to deal with anxiety, that allows him to be able maybe to get certain things done and to be a bit more comfortable. But like I mentioned, so these will be dependent on the obsession or on the compulsion that they have. But by and large, maybe what I can mention here, and this goes for all mental illnesses, ways, self-help ways for us to be able to improve and maintain our mental health. Exercise is very, very important.
Yeah.
Regular exercise. Sleep, very important. So having ample quality sleep, 6 to 8 hours of good sleep.
It's very hard for us to rest in our generation.
Yes, that's the thing. And it's causing issues.
Yeah.
Diet, so just having good, healthy nutrition. Having, the term that we use is meaningful relationships. Okay, so having people that you can be able to open up and share with and journey life with, and also finding meaning in work, finding meaning in what you do, and purpose and motivation. Those 5 things, we call them the big 5 for mental health. They are general self-help tools that you could say to just help us on the broad scale manage ourselves and keep ourselves in good mental state, good mental health.
Yeah.
But for each person, there will be other things that we'll need that fit into their setting. Because 3 people with OCD will not have similar obsessions and similar compulsions, right? So each one's treatment is individualized. It's tailored to the individual. It's one of the things I find very amazing about psychiatry is, if I can't go to therapy and give you my notes and say, go for you. No, just use mine.
Copy
it won't work because
your experience is
very different from your experience. Yeah. So my treatment will be very, very different from your treatment.
When you mentioned that there is a possibility of someone healing, are there chances of a relapse when it comes to OCD?
Yes.
Ooh.
Yes. Again, remember, there's a genetic predisposition.
Oh, that part.
So because I'm genetically predisposed, I'm always going to be at risk. But the goal of therapy, again, like I told you, as a psychiatrist, I'm trained not only in the treatment, but also the prevention, how to prevent these conditions. So we would have to train you on how to safeguard and protect yourself from the possibility of a relapse. So it's one of the things that we discussed. So we have a whole session pretty much on how do we ensure that this doesn't happen again or we don't find ourselves here again.
Yeah.
I mean, think of it like an illness. Think of it like malaria. Just because I got malaria once doesn't mean I won't get it again. But if I sleep under a mosquito net and I use the insecticides and I slash the bushes and drain the...
They slash the bushes.
then I can effectively ensure that I don't get it again. Okay, so is there a possibility? Is there a risk? Yes. But I can put measures in place to ensure that I don't find myself there again.
Do you feel like there are available support systems? You've sighed. Should we just skip it? Do you feel like there are available support systems for people struggling with OCD in Uganda?
No. Not that I know of. I think that's the best way to say it. Not that I know of. This is a condition that's not really well appreciated here. And that goes for most of the psychiatric illnesses because culturally and socially, we don't really pay attention to the mind. Right? I mean, for most people, do you have a fever? No. Are you vomiting? What do you mean you're sick?
Yeah.
Right? We understand sickness in pain.
Physicality.
In physical. And therefore, not much work has gone into getting people to understand psychiatric illnesses. Least of all OCD, right? Because if you look at it from a statistical point of view, it's not that frequent. Okay? So it's about 1 to 3% in the general population who will get OCD.
Yeah.
Right? So it's a very small number of people. And in our setting, very few of them will get diagnosed. Okay?
Yeah.
So we haven't yet built to the possibility of having resources of that kind. However, we now live in a global village. And I know that there are very many platforms, that offer support and different self-help groups that we can still be part of that are really global in nature.
Yeah.
Yeah. So I don't know of any in particular, but I know that they definitely would exist where we can have support and maybe, peer-to-peer support. Yeah, in that sense. But in Uganda, I do not know any. But hopefully we can start the campaign for that.
We could.
To change.
We definitely could. So mental health in Uganda, or Africa, continent-wise, is faced with a huge challenge of stigma. But for some reason...
so there are quite a number. I was just Googling here.
You just Googled some?
Yeah. There's one called Friends with OCD, OCD Tribe, Support for Everything OCD. Now, these are online support groups.
Oh, yeah?
Yeah. So there's quite a number.
So someone can always
Almost
Google.
100, yeah. We live in the information era.
People do not. Because let me tell you something. We have these gadgets.
Yeah, we don't
and
choose them.
all we think of is social media.
TikTok.
You find, yes, and the challenges.
Yeah.
Like, all you think of is go and do that. And yet, there are so many things that you can learn off your device, but people don't do that. I mean, you're still finding people posting things like, if you're struggling with mental health, it just shows that you don't have a life purpose.
Oh, wow. Yeah, that's sad.
You see that?
That's very sad. That's very, very sad.
And they have internet.
Yeah.
You're like, come on now.
But that goes back to what you were coming to, the stigma around mental illness.
But do you feel like OCD has stigma in Uganda?
But definitely.
I don't think so. Let me tell you. The way how this guy is coming up and holding the microphones, someone was fighting on social media. So I think he had taken a break and someone was trying to look for him. Someone made a post like, hey, where is this guy? And this lady wrote, he is in rehab. He went off so bad.
Yeah.
So bad. Totally different from the way how I just told you I was reading a book and OCD was being flashed everywhere. Yeah. It's not. So I was like, this guy is very selective with which mental illness they want to have.
You see, the root of stigma is ignorance. When you have ignorance, you have stigma.
Yeah.
Okay? Because again, when people throw OCD around the way they do today, then they are not going to give due attention to the one who actually has OCD.
Exactly.
They'll downplay it, right? It's like depression. Because everyone says, oh, I'm depressed. Oh, you're depressing me. And so when someone actually has depression, the disorder, right?
It's not serious.
What?
It's not that serious, yeah.
Everyone thinks, and that's stigma. That there is also stigma because then you're not going to pay attention when someone has an actual illness. I mean, think about the boy who cried wolf, right? And that's what we're doing here. We're crying wolf.
Yeah.
Everything has become OCD, so when the real OCD shows up, we won't give it the attention it deserves.
Let me tell you, I was taking a soda in someone's house, and I think it must have been in that period when I had bought a soda and I realized later that the tip was chipped.
Yes.
So when I was in this person's house, I felt something. And I got my torch and torched inside so that I can at least have an idea of what is in this drink. So this girl saw me and she was like, OCD. I was like, dude, I just felt something. I don't want to risk.
I see the difference. Why it's not OCD for you is there was reason, there was ration as to why I had to be cautious. Okay? If it was OCD,
like
there'd be no way to explain.
You're being diagnosed everywhere we go.
So that's the thing. That's part of stigma. That's part of stigma in itself because it's fueled by misinformation. The moment we don't understand what this thing is, we are effectively stigmatizing this particular situation. Because then we're going to come up with particular ideas around what it is, around how it should be treated. That's why they'll tell you, what? You're depressed? Come on, go to church. Or get out of it. Be a man. This person is stigmatizing because they don't even know what they're talking about. Okay, so there's definitely a lot of stigma around it. And of course, one of the ways that helps is having these conversations. And so Hashtag definitely doing a lot of work to break the stigma. And we need more of this. So the more the information goes out, then, the less the stigma and, the more support will be.
After reading the book, it felt urgent.
Yeah. So like I was saying, there's almost like 100 different
support groups
for OCD. I'm seeing here, Moms with OCD.
Oh, that's very helpful.
San Diego OCD, but many of these are in the US.
That's the problem.
Okay. So there's lots. There are just so many, and these are all support groups that we can be part of, even if we're not there. And then hopefully we can also begin to start some here.
Something that can relate with a Ugandan.
Yes.
Right. When it comes to interactions between OCD and other mental health conditions, I think, I don't know, you've been answering this a lot in the conversations. You've mentioned a lot of anxiety. So I take the floor. Anxiety is the only one that I can remember you talking about.
No. We have what we call comorbidities, right? So there are a couple of conditions that sort of
just walk together
along with OCD. Or if someone has OCD, they are very likely to get depression. They're very likely to get now anxiety disorder. Again, the anxiety of OCD is not the same as anxiety disorder. Okay, so those are different things, because I may have anxiety disorder without OCD, and I also may have OCD without anxiety disorder, or I may have both, right? Because again, the mind is not, or health-wise, it's not selective. It doesn't mean that because I have hypertension, I can't get diabetes, or I can't get HIV, or I can't get malaria at the same time. You know, all these things can actually happen at the same time. So you could have PTSD and depression and OCD and let's say dementia at the same time, right? Very unlikely, but it's possible. So the most common comorbidities with OCD are depression and anxiety, generalized anxiety disorder. They tend to move together many times. One can predispose to another. So you can imagine, for example, if this patient that I had who has OCD, and then she begins to cut herself from her family, cut herself from her society. She can't work. She can't, even be in her own house in peace. She could develop depression.
Right.
Okay. In that particular sense. And then remember, she had a very nasty experience being diagnosed with PTSD, with COVID-19 and having to go into those COVID isolation facilities and the like. So she could also have PTSD. Because of what she went through, right? So these tend to kind of like move together.
Yeah. Do you feel like there are some specific recommendations or resources that we may have missed in the conversation?
I think maybe the call for us to use our gadgets more, in the right way. I mean, let's look for information and real information. I mean, for someone to have Twitter as their reference, any one thing.
Someone could be disseminating the information.
I agree, but it's not always the right thing.
It's not always
the right thing, right? So, I mean, I want to be able to do a bit of fact checking, and I think that's something we should all learn, because we have a lot of fake news going around. As a result of this whole information age, anyone can post pretty much anything.
Yeah.
So it's important for us to be very clear on where we get our information, and who are we talking to, who is the authority here, right? I mean, if you remember at the start of the pandemic, the COVID pandemic, when everyone was saying everything about COVID, right? It was because of 5G and it's China trying to wipe us out of the world. And I mean, really, there could be nothing more far from the truth. But people had this. I mean, not just people, I mean, a certain president of a certain country that we know, was, and that can be part of what misinformation can do. So I think for me, the take home for all of us is, let's check the facts. Let's try to take a deep dive into these different topics and just try to find out the truth. I mean, before I diagnose my friend to have OCD, do I even know what OCD is? Have I taken time to read up about it, or to listen to a nice podcast from a reputable source, that's hosting someone who probably knows what they're doing, or what they're saying. And what do they say? What are they saying about OCD, right? So who's saying? I mean, I think that's something that we need to learn today is, okay, because we have a lot of information, how do I know what information I can trust and what information I should, be very careful about?
Thank you so much.
Pleasure.
Is there a way people can get in touch with you?
Well, I currently, with the Department of Psychiatry in Makerere, and so we see our patients in Mulago at the Bosa Mental Clinic, and also in Butabika at the National Referral Hospital. So that's where you'll be able to find me
So in
for
case
psychiatric services.
in case this resonated with you, we're asking you to check in with the facilities that are available. Bosa Mental Health Clinic is right there in Mulago.
Yeah.
Can someone just ask at the gate?
Yeah.
And be guided?
Yeah.
Yes. Mulago Referral Hospital. National Referral Hospital. Thank you so much, Dr. Agaba.
You're most welcome. You're most welcome.
A big shout out to Dr. Agaba Denis. I couldn't have done this without his expertise. And to you, the listener, thank you so much for hanging out with us to the very end. If you love this episode, do me a favor and hit the subscribe button in your podcast platform of choice. Also, feel free to share your insights about what connected with you on social media and be sure to tag us. We are at #time with Nabguzichwanka on Facebook and Instagram. And on Twitter, our handle is at HTNK Podcast, or you can use the hashtag HTNK Station.